Okay, so assessment and care of our newborn is our next topic. So in order to take care of the baby, you have to know information about your mother. So it's important to review the chart and it's important to review the chart. We want to know how old mom is she married? Oh, how many pregnancies this is for her, living children she has. All of this information is equally important, not one more than the other. Of course, we want to know her lab values, whether or not she's Rh negative. We'll talk about RhoGAM later. Her rubella status, all of those items. Okay, just looking at the baby, there's so many different things you can tell just by looking at the infant. Is it pink? Is it covered with vernix? We talked about vernix. Look at the cord. Is there one vein and two arteries? Does it have 10 fingers and 10 toes? And what does his ears look like? The shape of his head. So there's so much you can tell just by looking at the infant. So initially when this infant is born, of course, there's a process that we go through. We want to clear the airway. And used to be, and you'll still see providers do this, they'll take the blue bulb suction syringe and suck out the mouth and then the nose. And it's very important to keep the baby warm. So we want to make sure that our infant warmer is turned on to begin with. It's the nurse's responsibility that's assigned to the infant to do an APGAR score. And we'll look at each of these individually. And a gross assessment, what is that? That's just looking at the kid. Is he a funny looking kid? Well, I don't like to say that because first you want to look at the parents. Are they funny looking parents? So that's expected. But does it in that gross assessment, does it have those 10 fingers and 10 toes? Does everything look okay with this child? And what does the cord look like? Is it thick or is it thin? Before we even take the infant away from the mother, if we separate the mother from the baby or leave the room, the policy is to put identification bracelets on the infant. So we want mom to bond with the baby. What is bonding? Bonding is where she's holding the baby, touching the baby. Okay. Now remember, if you're the nurse, that you may want to make sure that you have gloves on if you're handling this infant. It hasn't had its bath yet. In I don't know how it is presently, but this last semester we were there, they were not giving babies baths initially. They were waiting a while. And so anytime you handle the infant, make sure that you have gloves on if they have not had a bath yet. And we'll talk about medications. They will be given medications in the delivery room, which is the vitamin K, Hep B, and the erythromycin eye ointment that the student, will be providing to these patients. And of course, I'll be there with you, no worry. So APGAR score. So this is what APGAR means. Is the infant active and moving? What's its pulse at? And so we want to determine these things within the first 1 minute and 5 minutes after birth. But you want to make sure that it's the full minute after birth before you actually assign an APGAR. Is the infant moving? What's its pulse? Is it strong and regular? Is it grimacing? What does it look like? And what are respirations? So those are things that we need to determine initially. So this is a chart of the APGAR scoring chart. So let's say this infant had no heart rate, so of course that's a 0. So APGAR score ranges from 0 to 10. And so we look at heart rate, respiratory, muscle, reflex irritability, okay, and color. Those are 5 things we look for with a score of 0 to 10, each with two points each. If an infant has an APGAR score of 6, below 6 or below, at 1 minute, that just means that infant needs a little help, maybe stimulation. Usually it's stimulation, because if you rub the baby's back or flick the soles of its foot, it's going to cause it to inhale and scream. And so that's generally, but if it's 4 or less, well, we're going to maybe need a team to help us get something going here. APGAR score of 6 or less means at 5 minutes means that we have to do another APGAR at 10 minutes. So this is all being documented as well. So this is typically what a warmer looks like. And so my infant, the head would be facing here, not here. The head is here because if I need help with this infant, then I've got space all around that I can have people come in and help me. Typically, well, in recent years, what we try to do is we don't take the baby to the warmer right away unless there's a complication. In other words, he's not breathing, there's no pulse, and we have to do something right away. Otherwise, we will ask the mom if she wants to hold the baby as soon as it's born and lay the baby on her chest. Okay, we can still um, obtain a pulse rate, listen for respirations, and do all those things while mom is holding the baby. Now, I did talk about thermal regulation. Now, babies can die from decreased temperature. So we want to make sure that we dry this infant off as soon as possible, and because evaporation will cool it off, and that we have the warmer on as well prior to birth. So, are there fans in the room that are running? We might want to turn those off and maybe close any windows that are open. We don't want this baby to cool off too much. So, these are convection. When we place the baby on the warmer, we want it to be warm, and we want to dry it off. So evaporation, radiation, conduction, those are ways that infants can lose or gain heat. Okay, so look at your environment is basically what I'm saying. So hypothermia, yes, babies still die from heat loss. They're very unstable in the first 24 to 48 hours. Even, let's say, for example, baby's temperature was within range, and you went back an hour later, mom had uncovered the baby, passed it around the room for family and friends to view, and you went in because it was time to take the temperature, and this infant was cold. So it's important to keep the infant wrapped up and teach mom how to take the temperature. We take temperatures under the arm, and have a hat on the baby because infants lose 50% of their heat out of their head. So, and again, that's part of educating mother about keeping the baby covered and wrapped. So if the baby's cold, he's not going to eat well either. So I've gone into the room with students to assess the infant before, and mom says he's just not eating, and he's done nothing but cry. I can't get him to eat at all. So the first thing that I did was grab a blanket out of the warmer, wrap the baby, put a hat on it, and once baby warmed up, it ate just fine. So we want to be aware of how it can affect the infant if he's cold. Of course, you'll see tachypnea and tachycardia, which you learned about that as well. You should have in Nursing 111, which is fast breathing and fast heart rate. So look at those signs. Ineffective thermal regulation. as I said, the first 24 to 48 hours, it's going to take time for that infant to adjust um, to the world. Identification, I kind of touched on that. So in a bigger hospital like Samaritan, usually we notify the secretary who calls the registration and they register this infant. There's actually two different bands that are placed on the baby. There's four bands altogether. That's before we separate mom and baby. We'll want to make sure this infant has an identification band on it. And there's a line of numbers and they're all the same on all four bands. One goes on baby's arm, one goes on baby's leg, says the last name of the mother on it and has numbers on it. And the other band mother gets, or and the significant other gets the fourth band. Okay, so baby has to be registered with registration to show that it was born, and of course mom will have to fill out birth records before she leaves the hospital. This is just showing you bands and what they could look like. They look different depending on which hospital you were at. Used to be we had to take the state required footprints. However, those are not required by the state any longer. And however, we do still do those if mom requests those out of courtesy for her. I'm going to just slip back to the bands here. So we do have identification bands, and there's also a security band that's placed on the infant that has an alarm on it. Is registered to be given to that baby, and it's usually on the leg. And that's so no one can try to slip away and take this baby. So we make sure that there's a security band on it as well, because infants are still being abducted. Now, yes, this is a little older one, but it still happens today where people try to take infants, snug or stuff them into a duffel bag or of some sort. And as a manager, one of the things that is required that you run a drill of an abducted infant on the unit twice a year. And you might not know if that's a real thing or a drill. So we usually respond to those if that so happens. And what happens there is all the doors are locked. It's in lockdown. No one leaves the hospital, no one leaves the floor, the unit, and no one comes. And we check any bags in case someone has stuffed a baby in a bag. And we don't open until the infant's been found. If you have to, let's say, take the baby to ultrasound with the nurse, you'll see that they can disable that security bracelet. However, you have to stay with the infant until it's brought back to the unit. There's an alarm that sounds, it's quite loud. Sometimes it's just a whoops on the alarm, but we always check the infant. So physical exam always starts with looking at the infant, listening, and palpating. So that's no different than you would do any other baby. So from everything we talked about, if you look at this infant, what does it look like? Well, it has vernix. It's covered with vernix. So what do we learn about vernix? Well, that could mean that this is a premature infant and then it actually was delivered a little bit early. Sorry, I clicked through that too fast. Okay. Oh, but it's nice pink baby, just from looking at it. It's nice and pink, so that's a good sign. So we're going to inspect. We're going to look at babies here. Milia, if you can, I don't know if you can see those clearly, but they're white bumps, white papules on the nose. Those are expected. They will go away. No, 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 no. Go on. They will go away. Sometimes moms tried to scrub them off, but it'll disappear in a few weeks. You don't need to scrub them even. Okay. And sometimes you'll see a strawberry marks on the baby. Those are anything like that. You want to make sure that you document it. Hold on, sorry. That is documented. Okay. So yeah, so document any marks like the hemangioma. So Mongolian spots are just that. They're spots. They look like bruises, but they're not. You'll see those in American Indian culture, African American, Mexican culture. They're dark blue or they can be purple. Usually located on the buttocks and the back is where I usually see them. It's important to make sure that those are documented. I can recall a parent bringing the infant to the emergency room because it was sick, and the doctor had looked at the chart because the infant was born in that hospital, and to identify any marks or anything that at birth because this infant had Mongolian spots, and there was nothing documented, and so therefore the physician reported the parents to CPS. And being the manager, the physician came back to me, and I talked to the nurse at the delivery, and she said, oh yeah, those were there at birth, but she never documented that. So that put that family through a lot of trauma because the physician thought the child was being abused. So anytime you see marks, raised elevations, anything you see, make sure it's documented. Okay, so port wine stains as well. So a friend, her little boy, his face is covered just like that in those. So this is from forceps. It can be damaged to the facial nerve of the infant due to forceps. Of course, we don't use those, rarely use forceps any longer. Those are, we used to call them salad tongues, where the provider will reach in and assist the baby to turn the baby's head and to so the baby can come out. It got stuck in the vagina. But we still use, some of the older physicians still use forceps, but you can see the mark that it left on this infant here. All right, so we as nurses are obligated to document everything you see. That's part of your head to toe assessment. Okay. And that's something that I will show you and we can learn in the lab with your hands on. I always start at the head. You have the bones of the head that actually slide over each other so the infant can fit through that 10 centimeter opening at birth. So if this infant was just born, it might still have what's called molding. And if it, let's say, it may have molding originally, but that molding should go away generally within the first 24 hours. You can see the difference here. Okay. But you still have to check, are those sutures, is what they're called, between the bones, are they overlapping? Are they widely spaced? Or maybe they're fused. This is another condition that can occur. This baby was in the vaginal opening for quite some time, and they use what's called a vacuum to attach to the infant's head to maneuver it, assist it in exiting the vaginal canal. And so it's more like a hematoma under the skin. This does a kaput. I can't ever say the last part, but just call it kaput. Um, it crosses the suture line. It goes across the suture line, which is different from a cephalohematoma, which is only on one side. It's just a collection of blood under the skull. You think about a hematoma. Would not be unusual to see the infant's eyelids are swollen, especially if it was up to his eyebrows for a while. And you might even see that after providing the infant with the ileotisin eye ointment. Some babies have a little reaction to it. Okay, so look at the ears as well. You can see in this ear, there's like a little node right there. Okay, and this one is inside. And the ears can tell you a whole lot, like this one, how it's flat, the cartilage is not firm. So this is more like a premature baby down here. The ears are soft, so if I was to bend the ear over, it would stay that way because there's no cartilage to help it to bounce back. Whereas the little nodes here, in utero, the ears are formed as the same time as major organs. And so you think about the kidneys, okay? And oftentimes we will see this, and the provider may send the child to have an ultrasound done on its kidneys, and may also make sure that the infant is putting out urine like it should. It could questionably mean that there's a kidney problem here. A provider might just have the patient follow up after discharge if the infant's voiding. So we want to make sure that infant is voiding. And of course, document. So oftentimes you get your nose bent out of shape. Yes, that can happen during delivery. But these are infants and they heal rather quickly. It's just something to take note of and document, yes. Oops. All right. Sorry. Right. Okay, so here we have what's called Epstein pearls. Um, and it's nothing to be concerned about really, but it's something when you look in the mouth that's you might see something like that. So this is called cleft lip and cleft palate. Sometimes you'll see just cleft lip, and other times you'll see cleft palate as well. So this is important because it affects the infant feeding, and it can be fixed by the provider, but it's remember to document this in the chart. Here we go. So for really large babies, you might also see a fractured clavicle. So if you put your hands on your shoulders and you feel your clavicle, which is around your neck, the bone, and you walk your fingers to the middle on both sides at the same time, if it was fractured, you feel a crunch or have a bump there. And the infant will not use the arm on the side that it is fractured at, that there's a fracture, and the grip might be off. Now, you tested grips when you came to nursing 111, so this infant's grip might not be very firm at all. And if you go to pick up the arm, he might scream severely. Usually, infants that are over 8 pounds, 8 pounds, 12 ounces, the first thing you want to do is check that clavicle for any fracture. Know what normal respirations are so that you can recognize abnormal. So in a neonate, it's different than a child. So normal respirations 40 to 60. And you learned about tachypnea, Grunting is never a good sign for a baby. That means that there's a problem here. Okay? And stridor and intercostal retractions means that infant's struggling to breathe. So we need to have some assistance right away. So as long as you recognize what normal is, hopefully you can recognize abnormal. And the infant can only keep that up for so long. So you can see the retractions here. Okay, that would be retractions. This infant's having a hard time breathing. He may have inhaled some amniotic fluid or other complications when he was delivered, or she, I should say. So this is a scale that sometimes we often look at to determine what kind of, how extensive the problem is the baby is having. First thing I do is look at its nose. Is the nose flaring? And then you look at the ribs. Are the ribs, can you actually see where the sternal retractions are? And what color is the infant? Is it pink or is it kind of bluish in color? So of course we're going to document data about this baby. Temperatures are always taken under the arm, and I'll show you how to do that correctly. Pulse, respirations, blood pressures, you won't be asked to do that as students. We take those initially, and that's it. But we do take O2 sats. So size matters, yes. This is appropriate for gestational age is about a 7-pound 4-ounce baby. Okay, that's appropriate. 5 pounds 12 ounces or smaller is called SGA, small for gestational age. An LGA baby is 8 pounds 12 ounce or larger. So there's different policies that coincide with, if this is a really small baby, we might have to add maybe doing a blood sugar. And same with 8-pound 12 ounce. So what is the policy when it comes to taking care of this infant you want to be aware of? So this is our, yeah, our little toddler that was born 9.5 pounds. So just because it looks like it's a healthy baby does not necessarily mean that it is. It's very deceiving, because an LGA baby, which is over 8 pounds 12 ounces, can have the same complications that an SGA baby does, which is 5 pounds 12 ounces. So you can see these, oftentimes these 5 pounds 12 ounces, they get shipped to Kraus Irving. That's our mothership, I call her. Another responsibility is to measure the head. Now I know that Samaritan does not measure the chest, and I'm not sure why, but measuring the head in macros, or an infant that has no brain matter will have a very small head, okay? And it could present with other complications as well. Or a large head could be fluid on the brain, so it's important to measure the head. A newborn screening is done for all babies, usually 2 or 3 days after they have eaten on a regular basis, and what this shows is their metabolism, how they're metabolizing food stuff, which is milk in this case. For each state, there are different tests that they do. New York has like 100 different tests: maple syrup urine disease, PKU, phenylketonuria. There's over 100 tests listed, and I usually have, or do not allow students to do this. It goes to a special laboratory, and you can see they're putting drops of blood on the circles here to be tested, and they have to be they're very particular. The Wadsworth Laboratory is very particular about this, and they'll send it back if it's not done right, and then mom will get ticked off because she has to come back in and she gets another charge because somebody didn't do it right. But anyway, but when this is done in the hospital prior to baby leaving, and mom will get a slip of paper that's saying that it's been done, and we tell her if you don't hear from them, that's good news. Okay, so. And if they do, well, the provider will be getting a hold of them. So prophylaxis, protection from disease. So one of the medications that we do at the time of birth is erythromycin eye ointment that's placed in the infant's eye. So what you want to remember is how to do that. And it's from the inner to the outer canthus of each eye, and make sure not to touch the tube to the eye itself. Okay, and that's a law. It's a state law that we provide those. Back in the 60s, there were a lot of babies that were born blind, actually, and prior to that. And what they discovered, it was because of gonorrhea, chlamydia, sexually transmitted infections that infected the infant's eye that caused them to be blind. So, can mom refuse this? Oh, yes, she can. She can refuse anything. Remember that. But what you need to tell her is, okay, you can refuse this, but I need to notify social work that you've refused it so they can come and talk to you. Usually, when you tell them something like that, they're like, okay, go ahead and give it. But you still have to do your job by notifying them if they continue to refuse it. And the most important thing is that you've educated your patient about why we're giving it, and that you have documented that and documented it and very carefully. Okay, so bonding. Bonding is holding the baby, rocking the baby, calling the baby by name, touching the baby. Um, those are specific things that we want to document that yes, this mom is holding and bonding with her baby and how she's doing that. We can't say just bonding. We want to be specific and detailed and how is she doing that. So at the time of birth is we want to make sure that she bonds with her baby, and one way that as nurses we can do that is, do you want to ask her, do you want to hold your baby as soon as it's born? And oftentimes mom will say yes. And maybe dad wants to cut the cord. Okay. So there's different things that we can do to encourage that. In breastfeeding, we want her to room in because we don't do the nursery anymore anyway. And encourage dad to get in there and participate. I kind of joke around with him and say, okay, you want to take this kid home, you got to show me you know how to change this baby's diapers. So I kind of joke around him when I say that. But we do want to encourage and document bonding. Okay. So in your database, it also asks you about bonding. And what I don't want to see written there is, yes, they're bonding. I want you to describe how are they bonding. And don't forget about dads. So baby has to adjust here as well, same as mom. So that heart rate, is it where it should be? Respirations. We're going to check out this kid head to toe. Excuse me. Okay, look at the APGARs. The APGARs will tell you if you need to watch this baby a little bit longer. Um, as I said, an APGAR is 6 or less. We want to take another APGAR at 10 minutes. So look at the history of the infant. What words APGARs will tell you to, even if it is stable, should we be a little more observant about it? So vital signs are every hour times 2 and every 2 hours times 4. And then we'll continue to take vital signs every 4 hours. So this is just the process of what happens at the time of delivery, okay? From the time that we dry and clamp the cord, and you can see it changes your PC O2 and your PO2, your acidosis from when the baby takes the first breath. Ultimate, and there are valves that close here. We have the foramen ovale, okay, and the ductus arteriosus. Those are valves that should close, and sometimes that foramen ovale, which is in the atrium, doesn't close right away. It may take about a week for it to close, so you may hear a slight murmur. Okay, where was it? Oops, sorry. So again, this is our head to toe assessment. This infant should have its first stool usually within the first 12 to 48 hours. So breast milk stimulates the intestines, and usually after breastfeeding, baby will have its first stool, and it's very thick and dark and black, and it's hard to get off. So you'll see the nurses will put Vaseline on the baby's bottom so it doesn't stick to them, because then you got to scrub it all off afterwards, and that can't be fun. So there's a difference between a breastfed and a formula fed baby, what the stool is like as well. But that first stool is always meconium. It's like the plug that was in there. And we want to make sure that we document all stools and voidings of the infant. Of course, at the time of delivery, we're looking for that one vein and two arteries, and keeping track of voidings, and we're going to look at genitalia as well, the female and the male. We want to make sure the majora is larger than the minora in the female, and look to see that where is the urethra opening at, and is the rectal opening, is it open, is it clear? And the same as the male, where is that urethral opening at? It could be on top of the penis, which is an epispadias, or it could be underneath the penis, or where is that urethral opening at? And we also test the scrotum. Are there two testicles there? And what does the scrotum look like? Is there rugae, which is like wrinkles on the scrotum? That's what I call it. That means that that infant is due. And if it was shiny and flat, that means it could be a premature infant. So there's different signs that we look for, and once you get your hands on, we'll explore those differences in babies. Of course, thermoregulation is first and foremost. Always keep the head on the infant and keep it warm. Especially we're getting into fall and winter here. One of the questions I always ask the mom is, how do you heat your house? What's the warmest room in your house? Because we want that baby to stay warm. And the first thing to do if we do have a cold baby is make sure we put it skin to skin with mom, because that's how it will capture the heat. And don't forget, dads can do that too. Oh, goodness. Okay, stay there. Okay, so they're muscle reflexes, and if you go to the library, and you can do that virtually as well or online, however you want to call it, and there are videos in the library that you can watch, and on your computer even, and the infant actually has 14 different reflexes, but the ones that I want you to be aware of and know of are the Babinski, the grafts, the moral, rooting, stepping, sucking, and the cry. Okay, so we'll go through each of those in our labs that we're going to have. So for an infant, there's periods where they're awake and alert, and then they're sleepy. That's to be expected. So just know that. And sometimes Right about 8 hours after birth, this baby is very sleepy and it's difficult to wake up. And that's when mom gets the most frustrated because she's trying to breastfeed it and it won't breastfeed. But once it comes out of that sleepy period, they do eat well after that. So, as I had said, there's a scoring sheet that some hospitals use. I have never seen Samaritan use it though. However, that there are more than Samaritan. Crowd serving, they do use this scoring sheet, a Ballard scale that looks at different parameters for baby, if it's large or small, to look at true gestational age is what it's looking at, evaluating. Okay, so some of the nursing interventions, we want to make sure this mom maybe knows how to bathe the baby. Oh, does she have running water? How to take care of the cord, how to clean the diaper area. All of these things we want to document and look for. Is she doing those things? Does she know how to do those things? And as a nurse, you may be the person that will be educating her. Circumcision. Well, back in the 70s, all boy babies got circumcised. That was a common thing to do. But nowadays, only less than 50% of people are. I think that's more of a cultural thing because we have so many different cultures in our society now. And it's, according to the literature, it's really not necessary, but people choose to do it for different reasons. So, um, and that's okay. The provider will ask the mother of a baby boy if she wants the infant circumcised. The thing that's changed about circumcision, we used to not give the baby anything for when the circumcision was done. We just strap them to the board and the provider would do it. Nowadays, we can give them Tylenol, we can give them injections. There's different things that can be done, and there's different methods of circumcision. One doctor may do it different from another. So that's important just to pay attention and watch those because on the unit you will have the opportunity to watch and observe a circumcision. If the provider says, "Hey, I'm going to do a circ, do you want to come watch?" I would recommend that you say, "Yes, I do." Okay, so we want to make sure also infants getting enough calories. So breast milk and formula is usually 20 calories per fluid ounce, and we'll talk about that more during a lab that we have. And okay, so in maternity, we don't say yes, mom, or mom is baby's breastfeeding well. We use what's called a latch score, and you'll get that should be in your clinical manual actually. And so it's sort of like an APGAR score. We score the baby according to how well this baby is latching on and how well mother's doing with it. Okay, is it facing baby or is baby facing mom? Is it sucking? You can see the jaws sucking, making movement. How is this infant doing? We talk more about that later. So here we have a happy mom and a happy baby. That's what we want. Okay, so again, make sure that you write down any questions that you have for me and so that I can answer them for you. Right, great, thanks. And that concludes our newborn assessment. Thanks.